All right. Thanks, Dr. Loken, and thanks everyone for having me. Hopefully you'll find this talk educational and hopefully somewhat entertaining as well. I've tried to include as many pictures as I can to keep everyone's attention on a Wednesday morning. So at the end of the presentation, don't be shy. If you have any questions, maybe jot them down as we go along in case you forget them. And then as we do that at the end, I'll maybe have you turn your microphones on so everyone can hear. Briefly, this is me. I finished pharmacy, like Dr. Loken said, and then went to podiatry school in Oakland and San Francisco, and then did my residency training in Washington, D.C., which if you haven't been there, it's a great place to visit. So many things to see, and the best part about it is that everything is free. So where we're going, just a brief history of podiatry and discussing what podiatry has to offer. And I'll review functional foot orthoses. Surgery is a lot of what podiatry is offering in the United States right now, almost to some people's criticism, but they're doing a lot of it. And then I'll get into the diabetic foot and discuss some of those problems and what leads people to diabetic foot ulcer, infection, and amputation. So going back 400 years ago, the providers then were termed barber surgeons. Things look markedly different today. I'd like to know how this provider's back held out in that position, doing that all the time, no proper chair or anything like that. But moving into about 100 years ago or so, I mentioned Dr. Charcot, who I'm sure most of you have heard of, who made great advancements in neurology and rheumatoid arthritis and joint diseases. And there's a foot malady or syndrome that we name in his honor, which is a degenerative neuropathic osteoarthropathy of the foot, and there's a lot of advancements made in terms of how to treat that. Unfortunately, a lot of times people end up going on to a below-knee amputation, but there's a lot of fixation that has gone into treating that problem. Some of the arguments have been to try and treat Charcot Foot a little more earlier with surgery, but there's very few people, very few providers, I would say, in the United States doing that. And that's a good example of the Charcot Foot, where the Achilles tendon is a major deforming force pulling that heel up. And what happens a lot of times is this midfoot becomes a rocker bottom. And the treatment usually is to keep people off their feet for a long amount of time until everything kind of calms down, which can take up to a couple of months. So this is a little bit dry to start off, so bear with me. I'll just go through briefly how podiatry came to be. This is Dr. Maurice Lewi. He was a medical doctor himself, and his father was also a doctor and immigrated from Austria to the United States. And he always remembered that his father complained that there was kind of a medical indifference to foot ailments. There wasn't a lot of interest in foot problems. And he went on to the New York State Medical Society legislature. In the early part of the 1900s, U.S. medical schools were fairly exclusionary. They would not admit women or African Americans, and they didn't like many Jews either. And a lot of the medical schools for podiatry were formed by doctors who disagreed with their policies. And it was about 100 years ago, 1916, that the first graduating class in California graduated from the San Francisco area. But it wasn't without difficulty. This is his quote: "Great difficulty was experienced in formulating some procedure concerning chiropodists. They were carrying on their craft." And that's what it was. It was a craft without legal authority. But if they were barred from performing their tasks, who would care for the minor foot ailments of the public? And he remembered what his father said. And so he resigned as head of the New York State Board of Medical Examiners, which, considering must have been a pretty significant step. He must have felt quite strongly about it. And takes over as head of the New York School of Chiropody, which he renames Podiatry as a more proper etymological term. And he reorganizes the school along medical school curriculum and hires mostly medical doctors to teach this. So here we are 100 years later. There are now 9 accredited U.S. schools of podiatry. It's a 4-year degree, and in the 80s there was about a 1-year surgical residency. In the 90s there was 2 years, and then I'm generalizing, and then the last 10 years it has moved to 3 years in an attempt to gain parity with our allopathic colleagues. So it's 7 years total now, and podiatry, American podiatry, is followed by BC and Alberta. There are different laws in different states. I forgot I'm back in Canada now. Different laws in different provinces, and I'm not sure exactly what goes on in Saskatchewan and Manitoba and the rest, but BC and Alberta definitely follow it. There's talk of a podiatry school possibly opening in Edmonton, but that's pretty much all it is just talk right now. So in terms of what podiatry has to offer, orthotics, I'm going to go into orthotics as part of my lecture here, but that's one of the big ones. Surgery, as I said, there's a lot of surgery being done in the United States. Ingrown toenails being corrected, fungal toenails, neuromas, diabetic foot evaluations, foot ulcer treatments. This is just a very, kind of limited amount, but definitely the crux of what podiatrists are doing, as well as trimming toenails and that sort of thing. Just to go over some brief terms, when I say valgus, I'm referring to more of a collapsed foot, okay, a foot that's sort of everted, all right, or flattening, and then varus is inversion. I'm sure most of you know this, but I just kind of want to go through that briefly. When I say the first ray, I'm referring to the big toe and the first metatarsal, and there are the accompanying other rays as well. So this is just to get you thinking about biomechanics, all right? This is very, very brief, but look at foot type 5. So the heel and the forefoot are both perpendicular. So people who have a foot type 5 really don't have any compensation needs, okay? They're pretty much already square to the ground. Foot type 1, if their forefoot's already flat and their heel's inverted, for them to compensate for that, they're going to have to invert their heel even more. So foot type 1 would be at risk for inversion ankle sprains, for example, and rolling over. Foot types 2, 4, 6, and 8 all have a perpendicular component, so their ability to compensate would be a lot easier. And this is from a paper published by a gentleman named Paul Scheer in California, and I just added on here just to get you sort of thinking about biomechanics of the foot, and I'll bring it up in a little while. Who is eligible for functional foot orthoses? Hallux valgus, for bunions, it can help sort of slow or halt even the progression of a bunion. Orthotics will likely never correct any deformity of a bunion. Once it gets to where it's at, it's barring surgery, it's not going to get any smaller. Hallux limitus, which I will explain these two differences soon here. Plantar fasciitis, chronic ankle sprains. There's evidence that foot orthotics will help us with our proprioception feel the ground a bit better. So if we are having issues rolling over, orthotics can help us feel the ground more. Achilles problems, and then tibialis posterior, which is usually from a flattened foot as well. So as a podiatrist in my training, my question I'm always asking myself is, what am I trying to do? People come and see me and they have a problem, and you're either trying to correct the deformity or you're trying to accommodate it. And you do those with certain materials. Now, graphite is incredibly rigid and strong. I don't think anyone could go running on a pair of graphite orthotics, but graphite is very good for controlling people's mechanics. Okay, and you can mix graphite, you can mix any of these materials together, and there's many materials, but I just wanted to give you sort of a shortened version that's of the most commonly used ones. Polypropylene plastic is used most often, and it can be semi-rigid, and it will be cut to the person's weight. Okay, so obviously if I have a 300-pound gentleman in my office, his orthotic is going to be much more rigid than someone who's 100 pounds. Corax or cork can be fairly dense. EVA is a material that is, it feels dense, but it's quite forgiving. I guess if as an analogy, you could think of it as sort of asphalt compared to concrete. It feels hard, but of course it's a lot easier for us to run on asphalt than concrete. And then plastizote is merely strict accommodation for diabetics who you need just a soft landing to land on, who have neuropathy. The image on the left, everything that is to the left of that arrow, if we think of it in terms of the axis of a door, so everything that pushes up under the ground reactive force to the left of that arrow on that left image is going to cause this person to pronate, because that's where they're going to rotate around that axis. Conversely, the image on the right, to the right of that arrow, that's going to cause them to roll in. So this is again just getting you to think of the subtalar joint and how we walk, and we all have a different axis. The one in the middle is most normal, where we sort of have an even push on either side, which prevents us from having too many problems. This is the Peroneus longus. It originates on the outside of the fibula as a muscle belly and comes all down around the outside of our ankle and goes underneath the foot as a tendinous insertion and inserts at the base of the first metatarsal. So what does it do? Okay, so the Peroneus longus, its role is to basically stabilize that first metatarsal. Okay, it's to keep it down. When we pronate, when we have abnormal mechanics, we have excessive, and when I say pronation, just basically think of pronation as a collapsed, flattened, flat as a pancake type of foot. With that flattened foot, we have excess medial pressure going against the first ray, and that pushes the first metatarsal up in the air. And that impairs the Peroneus longus from being able to keep it down, okay? Which I think should be easier for you guys to follow what I'm saying. And then when that first metatarsal goes up, the big toe has a difficult time moving over it, and we have a problem at that first metatarsal phalangeal joint, okay? As well, the plantar fascia will oppose any motion there when we have excessive pronation. This image didn't come out as well as I would have liked, but this just shows a pinch callus demonstrating that excessive medial force. It's going, all the forces are going to the outside of that foot, and they're pronating, they're rolling off that outside of their foot, and people develop calluses at the medial aspect of the first MTPJ as well as the interphalangeal joint of the hallux. Hallux being the big toe, which I'm sure you know. So this is the mid-tarsal joint, and it plays quite a significant role. It is combined to the tailondivicular joint and the calcaneocuboid joint, and it sort of has this relationship with the subtalar joint, subtalar being the joint obviously between the talus and the calcaneus in terms of our mechanics. So in a normal functioning foot, the subtalar joint will supinate. This will stabilize the mid-tarsal joint. And then the Peroneus longus can make its, as we call it, a plantar lateral moment on the first ray to help pull it down. Don't worry too much about the top couple of boxes of this graph, but just going back now to our 9-foot types, okay? So to just think about those 9-foot types for a second. If there is any problem where we compensate for those things, now we wouldn't compensate for type 5 because we're already perpendicular, right? But if we compensate for those things, we're going to be using the mid-tarsal joint to do that. So if we have a large range of motion available to us at the mid-tarsal joint, we can compensate for basically whatever we need to. There's really our feet don't really have any problems. But as this graph shows, if we have a small range of motion at the mid-tarsal joint, we cannot do that. And consequently, the first ray becomes pushed up, like I keep saying, and then we develop this thing called functional hallux limitus, or that's what we term it. So the first metatarsal phalangeal joint has a problem when we have a small range of motion at the mid-tarsal joint. So then what happens after that? Okay, so going down the left-hand side of the algorithm, if that first metatarsal phalangeal joint has a large range of motion and a large tilt in the axis, there's more chance for that big toe to move over. Okay, and that becomes a bunion. If it's a smaller amount of motion, it's a smaller tilt in the axis, there's basically just jamming. The big toe does not want to move much at all, and it just jams against the first metatarsal. And this actually is a good graph because it shows this is the same patient. So you can get two different pathologies on the same person. One's his right foot, the other's his left foot. And as you can see, about 80% of people will usually go on to have a bunion. That's why we see more bunions than, hallux limitus, or which becomes hallux rigidus, where practically the joint becomes fused. And when I say practically, I mean really, as you can see from these X-rays, the image on the left, this is like a stage 4 hallux rigidus. That big toe is no longer moving. Once it gets to the point where it doesn't move, it actually becomes less painful because now it doesn't move anymore. But in that process of it getting to that pathology and how advanced it is, it can be quite painful. The image on the right obviously is a bunion. There's nothing in the literature that tells us how big a bunion will get, or we can't predict. I mean, we know that if we run a marathon barefooted, okay, to really exaggerate it, that bunion will get a lot bigger, a lot quicker. But nobody can say, Doc, tell me how big my bunion is going to be a year from now. I mean, there's nothing we can do to guess that. We know that custom foot orthotics can help control those mechanics so that the bunion won't be as big. And wearing proper, supportive shoe gear as well will help. Now this bunion is, as you can see, quite large, and some people can have no pain with this type of a bunion, and some people can have the tiniest subluxation, and they're in a lot of pain. So there's also no correlation between the size and patient symptoms. These are some cursory lines drawn just to show you the relationship between the lesser tarsus and the metatarsus, which is what podiatrists, and I would assume foot and ankle orthopedists would do to assess, things prior to doing bunion surgery. And I just drew these on here just to show you that, obviously all feet are different. The yellow lines is what we call the metatarsal protrusion distance. We like the first and the second metatarsal to be within 2 millimeters of each other. If one's incredibly longer than the other, that's when other biomechanical problems can occur. If the first metatarsal is really short, people can get a lot of pain in that second metatarsal area because our foot's not designed to have so much pressure going through there. But if that bone's too long, it will have more pressure. Conversely, if the first metatarsal is really long, that puts it at risk more for jamming and preventing that big toe from moving. Weight-bearing X-rays are a podiatrist's dream. Okay, this is what we're trained to do. This is what we look at. We like to see if we can draw a line through the talus going through the first metatarsal, which this pretty much does. We know it's sort of more of a biomechanically sound foot. The red lines are showing the relationship of the first metatarsal and the second. We like those bones to be roughly parallel. As you can see, this image shows that first metatarsal is not that parallel with the second. It's not awful, but it's not that great. You also see a dorsal spur there. So you can see just from this weight-bearing image that this person's already got the development of hallux limitus at that first metatarsal phalangeal joint. There's a bit of a pathology there. They may be having some pain there. In fact, I think this patient was. The big toe is not moving over it as well as it should. We look at the calcaneal pitch. We look at that angle of the calcaneus, and is the calcaneus flat on the ground? Is it higher up? And then the green line is, again, the metatarsal joint. The fancy name for that is called the cyma line. We like to see that line being one contiguous line. We like to see the TN joint and the CC joint on this lateral view basically be one line. If there's a break either way, we know there's either flattening or there's more of a higher arch. So what's the problem with this? They're not weight-bearing. So if you are ordering X-rays for patients, especially if they're seeing me, I would love it if they were. If anyone can glean any of that information from what I just said from this image, talk to me after. I'd like to hire you. But other than evaluating for fracture and possibly, sometimes if you're looking for a foreign body, opening of the tissue planes on a non-weight-bearing film can be helpful. But otherwise, this doesn't really tell us much. And then things can get more interesting. I sent someone for a weight-bearing lateral X-rays, and I got the yoga position. And then also, I think feet should have a dedicated foot view. I mean, especially if you're looking at doing surgery on someone, you should have, a 1 foot on one image. So anyway, I need to take some flowers and go around to the radiology offices in town and persuade them a little bit, But this doesn't just happen here. It happens all over the place. It happens in the U.S. So when we check people for limb length discrepancies, obviously the most tried and true way is to get an AP of their entire lower skeleton, but you can get a pretty good cursory understanding if people are in a chair, as long as they're flush with the back of the chair. But if they've got this George Costanza wallet in their back pocket, it's really going to throw things off. So you want to make sure that they take anything out of their back pocket. So how do we make orthotics? You see orthotics everywhere. They are expensive. They help people. They frustrate people. My training taught us that the best way to make these is with neutral suspension casting. You're trying to lock the mid-tarsal joint, and you're trying to plantar flex the first ray. There's this thing that's been proven is called supinatus. So we have this acquired soft tissue contracture of our first ray that pushes it up when we walk. So we're trying to cast that out. And we're also trying to cast them away from their end range of motion of their subtalar joint. So this is basically what I'm trying to do. when I cast for people. I'm pushing up on the fourth and fifth raise to try and lock the mid-tarsal joint, and I'm taking my left hand there and I'm pulling down on the first ray to cast out that supinatus. And like I just said, we're trying to cast people away from the end range of motion of their subtalar joint. So we're trying to find just sort of where we can feel the head of their talus when we swing them around and get them kind of in the center. There's other ways to make them. You can use a foam box. You can use digital scanning. There's a lot of lab companies that will send podiatrists digital scanners because guess what? It saves time. It's less messy than plaster. It's fairly easy. You just bring it in the room, click, there's your image, send it off, and the orthotic is made. I don't think that or the foam box is as optimal as the plaster of Paris. I don't know if I have to persuade you much, but I feel like if you're taking someone's foot and just putting it in a foam box, you're pretty much just reinforcing what they already have. I mean, if they have any kind of a problem mechanically, I mean, you're pretty much just getting what they've already got. When you do cast for people, it's nice to get some calcaneocuboid flexion. That lateral column of the rear foot, which again, the calcaneocuboid is part of the mid-tarsal joint. So if we can, get a little more range of motion available there, going kind of full circle with what I was just saying before. Now, obviously, if we did this to someone, this is just a foot skeleton. If we did this to someone, our ligaments would tear and we'd be in agony. So you're never going to get that much flexion, but you're trying to get, a little bit, which you'll never get with a foam box because it's just this static sticking your foot inside. And I've tried to depict this to persuade you otherwise here. As you can see, the top orthotic made with neutral suspension is pretty much consistent all the way through. I dare say there might be an apex at that calcaneocuboid joint, maybe, but it's hard to see. But it's clearly different from the image below, which starts off pretty well at the heel, and then as it goes down, just kind of tapers off, and doesn't nearly support that rear foot as well. The top cover is another thing that you can see on there, and I find some orthotics that I've seen, the top cover is so thick that it's keeping people's feet from the semi-rigid plastic or graphite. So if you're trying to correct any biomechanical abnormality, if they're not touching the plastic, well, then what's it going to do? Or at least it's going to hinder that optimization. Also the length. I've gone through this whole thing talking about the subtalar joint and the mid-tarsal joint. We don't need any plastic beyond the metatarsal area. You don't need anything, so on the right image, this device, I would say, is too long. It goes all the way through to the metatarsophalangeal joints. It's still going to probably be somewhat helpful, but I would think it might be a bit cumbersome to walk on. So you really only need to go as far as with the plastic that you're using to the metatarsal diaphysis area. These are just some of the modifications we can make. There's top covers. There's something called a Kirby skive, which will help to push up people who have posterior tibial tendon pain. People who are obese will often benefit from a wider device. Heel lift can help people with either ankle equinus, which is limited ankle motion, or a limb length discrepancy. We can offload areas of the orthotic, especially in the forefoot, if they have any kind of ulcer or painful callus. And I'll show you these pictures here as we go through. So again, the top cover doesn't need to be any more than 1/16 of an inch. You could possibly argue that one on the left is going to be better for a diabetic who needs more accommodation. But I think otherwise it just takes up too much room in the shoe and compresses your toes. The top cover is nice. You don't absolutely need it. Again, it's not anything distal to the metatarsals. It's not mechanically going to do much for you, but I'd rather have my foot resting on something like that than nothing at all. So we have calluses. We're all familiar with that. Some calluses are really diffuse and superficial and affect just the epidermis. Some of them go deep. Usually these are from trauma. And people don't often know that they've stepped on anything or had any trauma, but they go through the dermis and into the subcutaneous fat. And unfortunately, there's really nothing we can do for these. Okay, we can't cut them out because, well, you can, but then you've got no tissue really to suture them back together. Plus, they've got to get on with their life and keep walking. So you're really just setting them up for even a greater callus if we try and excise them. So you have to try and breed them as much as you can. I keep looking into seeing if there's anything coming out more and more, but the cure for these are really tough. because there's that core that goes so deep that it just kind of builds back on itself, and that callus tissue keeps coming back. But you can offload it. You can mark it on your cast and make something that will at least give them some biomechanical control, and then that may not prevent the callus from coming back forever, but it will at least reduce the amount of time or reduce the frequency people have to see their podiatrist or trim the callus themselves. Some people have a really strong band of their medial plantar fascia, which is painful when they walk. And so we can cut out a groove into the plastic so that accommodates that. Heel posts are necessary for people with more rear foot problems, okay, stabilizing the back of their heel and allowing the rear foot and the subtalar joint to have more control. Not everybody needs this. If you don't have any subtalar joint or ankle problems, I find that the post on the right is adequate enough. And especially I've found being back in British Columbia, especially in the summertime, and even a lot of women are trying to extend their flats and their sandals that may have some depth to it. Basically outside of November through February, they're trying to wear other nice shoes, and a heel post just won't allow them to do that. It takes up too much room in it. So if you can make a device without a heel post, they'll be able to kind of get away with not using a regular running shoe and putting it in something nicer, like I think this is a Jimmy Choo. I thought somebody might like the Jimmy Choo reference. And you can always use your orthotics in different shoes. People always ask, well, do I have to put this in one pair of shoes? No, you can wear them in any kind of shoes as long as it will fit them. And just briefly, I'll touch on shoes. We want our shoes to have a rigid shank. We don't want to be able to take the heel and bend it to the toe. If you can do that, it's not very supportive. We want to have a strong heel, so you can't. If I can take my thumb and bend your heel down, you're not getting any support at all on your Achilles or in your subtalar joint, and it's just the best thing to wear. Now, if anyone can ever invent something that is professional and supportive for say a female attorney walking into a courtroom, I mean, she can't walk in wearing these. So if anyone ever comes up with something that's going to get the best of both worlds, that's professional and has that support, I'm sure you'll be a billionaire in no time. So transitioning very abruptly into the diabetic foot and the problems that people have with diabetes, what's the causal pathway? How do people end up getting into trouble? Okay, so they end up getting an ulceration, which leads to an infection. Now, if that infection goes to bone, that infection, that bone has to be cut out. There's some evidence for IV antibiotics for 6 weeks, but if you've seen osteomyelitic bone in surgery and seen how destructive and destroyed and worn out it is, it's gone. You're not gonna bring it back. You can't heal it. And so that's really the causal pathway that so much of the world is going through. Very briefly, some statistics from the CDC. More than 20 people are diagnosed in Canada every hour with diabetes, and it affects about 9 million Canadians. There is this distinction between diabetes and prediabetes. In the United States, 86 million have it. So they're certainly ahead of us. When I say a diagnosis of colon cancer or a diagnosis of a neuropathic foot ulcer, I mean, I'm no different knowing even what I know. Colon cancer scares the heck out of me even more. But as you can see from this graph, looking at a 5-year mortality, they portend the same risk of death within 5 years. Obviously, the ones on the left, prostate, breast cancer, Hodgkin's lymphoma, and then the ones on the far right, the much more ominous lung cancer and pancreatic cancer. But for a lot of people, below-knee amputations, ischemic foot ulcers, peripheral arterial disease, these things are extremely devastating and need to be kind of thought of as more problematic than maybe sometimes we think about. So our sugars are high, okay? So we have a weakened immune system. Our white blood cells can't go in and fight infection as well. This allows bacteria to settle into our skin and our nails. It's very difficult to treat. As you can see from that fungal nail in the center picture there, this extra thickening of the nail puts more back pressure on the skin of the toe, and when you combine these other symptoms of diabetes, which I'll go through, really puts people at risk. Claudication, when patients walk, if they have claudication, they're going to have a repeated history. I can walk 4 blocks before I have to rest. Diabetes has a significant association with atherosclerosis. It's also potentially going to cause gangrene of the toes, and it's a major cause of heart attack, stroke, and kidney failure. So like I just said, peripheral arterial disease will develop a whole decade earlier in diabetics. We check for pulses in patients' feet. That's always a great thing to do. If we feel a pulse in someone's foot, does that necessarily rule out they have any ischemic problems at all? Well, no, it doesn't. It mostly does for the vast majority of people, but patients may have hypertension the day you see them, and that gives this false impression they have this palpable pulse. There's more evidence showing that whereas we know we have clogging of the arteries in our femoral arteries, like I just mentioned, claudication, in terms of the toe area, there's really no occlusive lesion. There's more of this thickening of the basement membrane and endothelial kind of dysfunction. So we know more about that. So even though we feel the pulse at the midfoot of the dorsalis pedis or even at the posterior tibial, it doesn't necessarily mean that there's enough blood flow getting to the toes for patients to heal either their foot ulcer or bring antibiotics down to cure an infection. You're going to use the same hand to test the same foot on the dorsalis pedis. So your left hand checks the left foot, your right hand checks the right foot, and the converse is opposite when you're checking for pulses on the posterior tibial. The right does the left and the left does the right. Sometimes patients ask me, well, I don't understand. I have a loss of protective sensation, and I also have nerve pain. So why do I have pain when I'm feeling this, and I also am at risk for not feeling things? And we broadly term both of these problems peripheral neuropathy, which it is. But what happens with high sugars is that the sugars go in and they kill the nerves, and there's different theories as to why that happens. Does the sugar actually kill the nerve itself, or does it osmotically pull in fluid and drown the nerve? But either way, the nerve's being damaged. And it's this regeneration of our body trying to bring our nerves back. And actually, it's similar to blood flow. When we have blockage of our arteries, if you ever look at an arteriogram of the lower leg, you'll see all this collateralization. There's no blood going through the main vessel, but there's all these wispy lines. And the same thing happens with nerves. It's our body trying to regenerate nerves, and these painful sensations are felt more proximally in our central nervous system. But you'll see and hear a lot of stories of people, say, stepping on a razor blade in the shower, and they don't realize it, and they walk around the house, and they've trickled blood all over their carpet, and that's when they finally kind of know something's wrong. What else do high sugars do? Well, they don't just deposit in our nerves, they deposit in our tendons too. So they'll deposit in our Achilles tendon, making the Achilles tendon an incredible deforming force. Okay, the tendons become less pliable. So you have this just, catastrophic confluence of loss of protective sensation, poor blood flow, risk for foot infection, immunopathy, inability to fight it. And now you've got foot deformity on top of that. So you've got all these high pressure points. You've got all these prominences of the metatarsal head areas. Extra depth shoes can help for people with hammer toes, so there's less of this going on. So who's really at the highest risk? Well, most of the evidence shows that a hemoglobin A1C of 9% is people are more than likely going to develop a foot ulcer if they're not protecting their feet. Now, just because someone has an A1C of 8, does that mean that they're free and in the clear? Well, no, but and they should still be referred to a podiatrist or a foot and ankle specialist. But 9% it is very high. Unfortunately, in my year back here in practice, I haven't talked to many people who've ever reported this. Most people are very well controlled. So it's certainly a different picture here than what I saw in the United States. History of amputation, which I'm going to go through in my last case as I conclude, is the number one risk factor for foot amputation. I know it's sort of silly to say, but the number one risk factor for foot amputation is previous foot amputation. Once it happens once, they're really setting up themselves for more problems after. So rigid foot deformity, limited joint mobility. I won't go through the different tests for checking for neuropathy. There's different things, but obviously a loss of protective sensation. Patients are going to have problems. And then there's also this evidence that at 10 years, there's kind of more of a risk for problems. And I think that that's just the amount of time where people's blood sugars have been uncontrolled enough at times where they start to get enough neuropathy to have issues. So a long-standing diabetic is more at risk than someone who's diagnosed, say, last year. Recidivism, what causes people to fail? What causes people to require secondary amputations? I mean, these are the 5 major things: plantar ulcers, osteomyelitis, neuropathy, ischemia, and their poor metabolic control. So I was just in Washington, D.C. at the Diabetic Limb Salvage conference just this past weekend, and it's looking at a team approach. And you need to have everybody on board to help these people if we're going to try to save their legs. You need your vascular surgeons, you need your podiatrists, you need your nurses, your hospitalists, your prosthetists. I should have put physical therapists on there. They're also crucial. One of the points made at the time by someone that for those of us who are not diabetic have the luxury to not even think about. I mean, a diabetic diet costs a lot of money, and that was one of their arguments. And another reason why they probably have poor control. They have to really watch themselves, and it takes more out of their wallet. And they have to be perfect. This team has to be perfect. There's evidence that I saw that showed once you take away one of those, cogs in the wheel, that their amputation rates will go up. Now, there's not very many of these multidisciplinary teams, I guess, in a lot of different places, but it's certainly advancing in the U.S., and I'm not sure we'll ever have one in Kelowna, but hopefully one day. So transmetatarsal amputation, and this is sort of my last part of the presentation. This is the go-to definitive procedure for people. If they have osteomyelitis or gangrene of their toes or the metatarsal head areas, we're trying to provide them with a stable plantigrade foot, okay, that they can walk on. When I was a fourth-year student 6 years ago, most of the evidence showed, when do you do a transmetatarsal amputation? Okay, if they've had a previous big toe amputation, if they've had 2 or more rays taken off already, or if they have significant forefoot deformity. We know now, the evidence is showing, and a lot of these studies, of course, are retrospective, but we know now that half of patients within 1 year of hallux amputation will undergo a secondary amputation. So we're seeing more and more that, are we really just setting these patients up for failure if we take off their big toe? We know, and then as we term it, whittling away. And you come in 6 months from now, we'll take off another toe. You come in 6 months from now or less, we'll take off another toe. And we used to kind of think this was, you're trying to save as much of the foot as you can, but when you leave this, abnormal biomechanical positioning where these toes don't have the support they have. I mean, the foot works as a team. So once you take one off, there's more pressure that's going to be distributed to other parts. So now we're looking at, do you go all the way to a transmetatarsal amputation just when they have infection of their big toe? Or even of a lesser toe? It's tough to persuade patients of this. I mean, this gentleman's already had a partial ray resection on the 5th metatarsal, and now he's got, obviously, multiple toes affected. This gentleman absolutely needs a transmetatarsal amputation. But what does this patient see? Well, my 3rd toe looks pretty good. My 4th toe looks pretty good. So, no, I don't want a transmetatarsal amputation. I think I'll need those toes for balance. And these are the arguments you'll hear from patients. You have to, if you give them an out, if you say, well, this might heal, they'll go, okay, well, we'll try that then. You really have to persuade them with the evidence that we have, that their best chance for saving their leg is to go to a transmetatarsal amputation. And so he didn't agree to it. And I mean, how well do you think this did? Well, before even the incisions could heal, he developed a cellulitis. And as you can see pretty clearly there, And he was converted to a transmetatarsal amputation, as well as that medial side you can see is not really, it's still kind of open. I'm not sure if he had a vac on it or not, but. Clinical pictures are a great way to get your message across in PowerPoint presentations. I always, you can't underestimate the use of a backdrop so your viewer's looking at the picture. I mean, here you can see this person's, we're staring at their pants that are 3 sizes too small. So always try and have a backdrop so that, you get your viewer looking at what you want them to. Is this the right decision? Is this going to last for this patient? There is evidence to show that lateral ray amputations will have a better chance. I mean, most of the weight when we walk is borne through the first ray. So that fourth and fifth, maybe I would say, it's impossible to predict, but I mean, they're going to have a better chance of lasting at least a year with this than if they had their great toe removed. And of course, time is tissue. Okay, I mean, if you do leave these things to chance, that plantar flap that looks pretty nice there, which is what should have been done in the first place. If they go around and walk on that even further, if that plantar skin then becomes ulcerated and infected, now you've lost, you're burning bridges, right? You can't close them as easily. So that pretty much concludes everything in 7 years I learned in podiatry in 40 minutes. So if anyone has any questions, I'd be happy to take them now. Go ahead. Sorry, is your mic on? Do you mind if...
Are your services all full MSP funded?
So in 2001, the British Columbia government took podiatry off the medical services plan. And I don't know if it's ever going to be put back on. So there are some small amounts of coverage for people on premium assistance, but no, we're not covered. Some private insurance companies will pay for custom orthotics and some visits, as well as Veterans Affairs, but the government is not covering podiatry. No.
Okay, simple question. Is your office PACS linked for viewing X-rays, or do you prefer to order your own films?
So I have been granted access to the PACS system, which I'm forever grateful for, and so I've been able to look at images online for patients and kind of review their X-rays with them, and I find patients have been enjoying that. They've been able to look at their own foot, and I can explain why things are going on. So I do have access to the PACS system, and I guess I wasn't trying to be too critical of the radiology technicians who are taking the images. I mean, they do a great job. I was just sort of showing that you can get things that are not going to be always helpful in terms of evaluating for feet, and weight-bearing films I think are just a better film overall. Come on, there's got to be one more question. Just one more. All right, go ahead.
You showed a picture of a plantar keratoma, and I thought if I saw that in the office, I might be thinking it's a plantar wart. So how do you distinguish the two? And obviously, if it's a wart, we treat it with liquid nitrogen. If it's a keratoma, you wouldn't want to do that.
So if it is a wart, you're going to be looking at sort of that cauliflower appearance. You're going to be debriding it. Warts are incredibly vascular. So as soon as you debride into it, you're going to have blood right away with a wart. You're not going to have blood right away with an intractable plantar keratoma, and if you are, then that person shouldn't probably be trimming it. So that's pretty much, it's tough to confuse those, unless you start mixing in something like really sinister, like a squamous cell carcinoma, where you don't know what the lesion is. I mean, it should be pretty obvious to a podiatrist whether you're looking at a keratoma or a wart. And in terms of how to treat warts, I haven't found that liquid nitrogen is really something that works well for me. Now, there's a million ways to treat warts, which shows that there's not really any one good way. So there's a lot of different options. I find just debriding it and exposing that papillomavirus, and then the patient applying topical acids, then that will work. I mean, acids just strictly to the wart without any debridement is not going to probably do very much because you're not exposing that virus. It's a little bit painful, obviously, but you've got to kill the source of the problem. So I don't know if that answers your question, but that's
Maybe you could just add what kind of acid you have them apply and how often they apply it.
I have had, I mean, keeping in mind I'm only been in practice a year, but I've had pretty good success with any topical acid, whether it's compound W, whether it's salicylic acid, or dual plant or other kind of mixtures, and they should be putting it on. I've had them put it on twice a day. So after in the morning, put it on. There's some evidence that occlusion and under occlusion will help. Some people use duct tape. I mean, I think that would be kind of weird to walk on, but even a Band-Aid. But just kind of, as long as they keep hitting it after it's been debrided, they can start to get some success. There's some evidence for cimetidine, the H2 antacid blocker, in kids. I know that's, people think, why would you give cimetidine for warts? It actually stimulates the immune system to recognize that virus is there. But it seems to have more evidence in youth than adults. So I've tried it on one 15-year-old, or maybe it was 13, but it worked pretty well. So, but thanks so much for having me. I hope this was somewhat informative and gave you an overview of podiatry and foot problems. And thanks very much.